Hello, I'm Dr. Philip Blair, and I'm coming to you through Elixinol to talk to you about arthritis and cannabidiol. Now, cannabidiol can offer some extraordinary benefits for treatment of all different types of joint diseases, and I'm excited to tell you about some of the details that I've uncovered and some of my experiences. Our agenda is going to include the burden of disease, the conventional cause and treatment, endocannabinoid deficiency as found in arthritis, as well as evidence for cannabidiol specifically benefiting arthritis of all types. We'll talk a little bit about serving sizes and management, and then I'll open it up for questions and give you a folder that you can look at other references that I have and other notes that I've taken. There is also a summary of the slides that's available in that folder as well. So the spectrum of arthritis is quite encompassing, and I've just outlined it in a broad sense so that you're oriented towards what we'll be discussing or what we'll be talking about. I'm going to stay focused on the degenerative and autoimmune, but what I have to say is going to have applications for traumatic as well as infectious type of diseases, as well as foreign bodies and anything that toxins that can get into the joint. First off, about the burden of disease for arthritis. We're talking about 53 million Americans who have this disorder, one form or another. 20% prevalence of arthritis within our population. Now, in the world, it's only about 4%, but we have a large majority in the older age groups outside of the working age, and these people have much higher rates. Now, the total cost, this is low at $556 billion because the projections are in the next year or so going up to $1 trillion. In hospital costs alone, this is probably the second most expensive procedure and reason for hospitalization right now for joint replacement or arthritis of one form or another. And the other part that people don't realize is that heart disease is very closely associated with arthritis. There's a very close approximation of the number of people. If you have heart disease, if you have arthritis, you also have a high risk for having heart disease. And the same is true for a number of other diseases that are inflammatory in nature, that the inflammation lends itself to one of these other arthritis types at the same time. So we're going to talk about the pathways of disease here, because that's, as an engineer, I'm very interested in specifically those pathways and how it works. I like to get down into the guts of things to find out why things do what they do. If we're looking at arthritis injuries, I just want to orient you to the structures that are here. We're mainly going to be talking about the synovium and about the cartilage. And then I'm going to go into some discussion about the neurologic, because this is going to be a real surprise, I think, for everyone to understand about the neurologic connection and the neuropathic connection for chronic pain related to arthritis. First off, let's use the example of rheumatoid arthritis. Clearly, this is an autoimmune disorder, and it's involving mainly these types of cytokines, the interleukin-1b, the interleukin-6, and the tumor necrosis factor. And I've picked these out. There's others that are involved, but I picked these out specifically because there have been developed biologic agents, antibodies, or receptor blockers that can work on these particular targets and modify the course of the disease. So if we're looking at rheumatoid arthritis, here we get the idea this is a bit of a vicious cycle. There's an autoimmunity that occurs, there's a genetic predisposition, and there's an activation of the innate immunity. And that happens centrally in your organ systems. And then it transfers to the target organs. And for rheumatoid arthritis, looking at the arthritis portion, we're talking about the synovial inflammation and the cytokines that are there. That the T cells and the inflammatory cells actually migrate into those tissues, particularly the synovium, and they start to produce their destructive and their inflammatory signals right on that spot. And then becomes a vicious cycle where once that process has started, there's a recruitment for more of the lymphatics and the lymph cells that are going to be involved in that particular issue. When we're looking at rheumatoid arthritis, at the autoimmune phenomena, we're talking about an interplay between the macrophage, the fibroblast, and the T cell. The T cell is going to come in and it's going to activate the macrophage, which is those primary immune function cells that's really doing the grunt work for the army of the immune system. And it's producing a lot of these cytokines, these inflammatory cytokines. At the same time, it partners with fibroblasts, and the fibroblasts are there also working on that particular tissue. These are sometimes called synoviocytes. It's local area, and they have macrophage functions, but they're all working together. And it becomes a vicious cycle where there's a recruitment and an inflammation, and quite a number of inflammatory substances are being produced. Now, the body has the ability to produce anti-inflammatory substances, but in this case, for rheumatoid arthritis, that seems to be lost, and there is an accelerating cycle towards inflammation for all of the tissues that are involved and the particular joints that are involved with rheumatoid arthritis. When we're looking at osteoarthritis, we're actually looking at a problem related to the articular cartilage, not so much the synovium. Although there is some inflammation in the synovium, it's nothing like what you see with rheumatoid arthritis, where rheumatoid arthritis is primarily a synovial disease with the soft tissues and the inflammatory reactions that's going on. The cartilage is essentially avascular. It doesn't really have much in the way of blood supply, and it doesn't really have much in the way of nerves. And so some of that pain sensing and those nerve sensing is actually coming from the synovium. But more on that a little bit later. After the cartilage has been damaged and changed, there are specific things that happen. Now, with osteoarthritis, this is primarily a degenerative type of problem. It's not an immune, it's not an autoimmune disorder. Almost all of these diseases involve the immune system. So in this case, I mean to be precise, it's saying that it's not an autoimmune phenomena that we recognize. Within the joint area, and particularly the cartilage, there are chondrocytes that are making up the primary cellular component, and it's surrounded with a matrix, and that matrix includes collagen as well as proteoglycans, which are fluid attracting type of substances, whereas the cartilage and the collagen resists and pushes that away, but it's contractile. So when these things get in combination, there actually is that spongy effect that occurs in the cartilage as a result of the contractile nature of the collagen and the water-absorbing properties of the proteoglycans. And so you get that sponge-like effect and that rubbery sensation and consistency that allows for the protection of that bone, preventing bone-on-bone type of damage and injury. Now, the cartilage is very active, just like the bones, and so you have it turning over constantly. When it happens that too much of the degradation enzymes are prominent, then you're going to have a breakdown of the cartilage. At the same time, maybe you have a decrease and a minimal number of synthetic enzymes. You're not going to produce the materials, the proteoglycans or the collagen that needs to be there. And these things have to be in balance. Otherwise, you create a degenerative condition for the cartilage, and with a gradual breakdown and a loss of that protection between bone to bone. So typically we see this as some sort of injury that occurs to the chondroplast, whether that's age or that is toxins, infection, whatever the injury is, or even trauma and stress. All these things play an impact on these particular cells. But the bodies and the joints' lack of ability to repair and replace those major components, the collagen and the proteoglycans, in the right ratios leads to gradual destruction of the cartilage, and then that bears itself to allow bone-on-bone grinding that will produce problems. But here's the real surprise, that most of the pain that's coming from osteoarthritis is not coming from this cartilage, and it's coming from a neurologic source. And what I mean is that it's coming from the spine. And what I have here is an image of a neuron in the spinal cord. And this neuron has been activated by injury to a joint. So get this concept that the joint is injured or damaged, or there's an inflammatory process going on in that joint. That signals back to the dorsal root ganglion, those neurons that are there, and signals them that there's something going on in this joint. At the same time, that neuron is sending information as well as signals to the joint and to the structures around the joint to increase the inflammatory cytokines, as well as to increase the pain sensitivity. So most of the problems that are related to chronic pain related to osteoarthritis, and probably all of the arthritides, is a spine-based neuropathic problem. And the evidence for that is examples like in osteoarthritis, where the degree of disease that's seen on X-ray is in no way in proportion to the amount of symptoms that people have. And even people who've had total replacement of their knees or other joints have not always found complete relief. And that's because the spine and the neurons in the spine are active in this particular process. That's also the reason why a lot of the agents that we use for osteoarthritis and for pain related to arthritis are working centrally or on the spinal column to modulate the neurologic signals and the neurotransmitters that are involved. If we look at conventional treatment for arthritis, I grew up when a time we were talking about rest, ice, compression, and elevation. Those were the key functions about treatment modalities that you use for any type of joint injury of what's going on. And furthermore, then we would go on to using non-steroidal anti-inflammatories as being very popular. And then if that wasn't enough, especially with the immune and autoimmune conditions, we might be looking at cortisone, or what we call the DMARDs, those agents that are disease modifying and agents that could impact the immune system in a number of different ways, but they're rather collection to sort of suppress the immune system and modulate it so that you can get control of the pain, as well as hopefully the destruction of the joints that are involved in the continued deterioration. In addition, we have new biologic agents that are coming out and one of the most prominent are the tumor necrosis factor inhibitors. They're working somewhere within the tumor necrosis factor receptors or the agonists, and they're blocking those particular effects. And they've had a very prominent role in helping prevent both the pain, inflammation, as well as the progressive joint damage that occurs. So very positive effects. Unfortunately, in some cases, they're only effective in about 30% of patients who are using them. And there are a number of toxicities and side effects that are related to these agents, as well as all of the biologic agents that try to be a silver bullet to take care of one particular aspect of an inflammatory condition. And then more or less we have joint replacement as the top of the therapy, with the idea that, golly, if we've got a destroyed joint, let's just replace it, and that'll solve all of our problems. But as I mentioned, in not all cases, because we have neuropathic pain pathways that are involved with this disorder, with all of the arthritides, and you may still need to use other approaches to control the pain. And I want to say just something about the pain modulators specifically, and about opioid treatment. It turns out that opioids have an immunosuppressive quality to them, that they inhibit T cell functioning and they deplete the lymphocytes. There's reduced numbers of killer cells that are activated when the dose of opioids are modest or at increased level. And it varies with the particular ones. But as a result, we're seeing an almost 100% increase in the rates of infection, joint infections, related to opioid use and arthritis of any kind. Within the endocannabinoid system, you have a major opportunity, because what we see is that there is a significant endocannabinoid dysfunction that's going on with all of these joint problems, that there's a shifting and an increase in receptors or with agonists, and that these are patterns that we see in a number of endocannabinoid deficiency types of problems, like irritable bowel syndrome, migraine headaches, and chronic fatigue syndromes. Arthritis may not be a whole lot different. We're seeing these manifestations in terms of the shifting receptors, agonists, and the metabolics that are involved with it. In one case, what we have is an evaluation for the endocannabinoid receptors that are involved in the neuropathic pain pathways. And I want to emphasize that these neuropathic pain pathways are important not just because of the pain, but because of the continuing the continuing damage to the joint, because this neuron is actually signaling the structures around the cell to go in an inflammatory mode and to shift even the metabolism of collagen fibers. And that is particularly true for the MMP enzymes that are involved, both in the spine as well as surrounding and within the cartilage and the cartilage matrix substance that is providing for the general disintegration of the cartilage. Now, as we said before, that's a natural process that turns on and off, but the emphasis coming from the neuropathic area is for destruction. What we see in the potential here is that we could control and reduce this dysfunction within the endocannabinoid system and rebalance things and restore both pain control as well as inflammation in the joints. Cannabidiol has specific action within the endocannabinoid system, as well as these broad range of receptors, including blocking the tumor necrosis factor alpha. So that's the one that we're creating $36,000 courses of drug therapy with these biologics that are required on a monthly basis, $4,000 a month, and huge costs that are involved. CBD does the same thing as Enbrel. It can take action. Now, Enbrel's got a high rate of toxic effects, but with CBD, there are no significant side effects and no toxicity, and you can get control with it. In addition, cannabidiol is working on the vanilloid receptors, the TRPV1, that are very much involved with pain, and COX-2. Now, COX-2 is the whole point of using Celebrex, which is a COX-2 inhibitor. CBD is doing the same thing as one of these very expensive non-steroidal anti-inflammatory and probably considered the most effective. And it's taking action right within the joints for this particular problem. I mentioned before that it's inhibiting the MMP enzymes that are involved with the destruction and the degradation the collagen fibers. This would prevent the destruction of those fibers and maintain and even prevent the progression of osteoarthritis in many people. CBD is going to modulate the cannabinoid 2 type of receptor, which is very important in these inflammatory pathways. Typically, when inflammation occurs and the CB2 receptors are typically involved with the inflammatory cells, there is a significant increase in the number of receptors that are present. As a result of CBD's action, it will modulate those, that they'll have stimulation to effect a anti-inflammatory pattern to reduce those inflammatory cytokines, but increase the anti-inflammatory cytokines like interleukin 4 and interleukin 10, key points in the processes of inflammation. In addition, cannabidiol is acting as an inhibitor to the FAAH, which is the breakdown product for the endocannabinoid system, anandamide, and the 2-AG. So it's promoting the natural agonists that are within our body, and it's stimulating the number of endocannabinoid metabolites, synthesis, as well as receptors and the agonists. Now, CBD is immune modulating as well. We haven't really gotten too far into that, but this is the pattern that we're seeing always, where CBD reduces the number of macrophages, and that includes synovial cells. It decreases and modulates the cytokines. It protects against glutamine metabolism. And this is a factor that leads to apoptosis, or the loss of many of those cells and the death of many of those cells. It helps maintain those. Again, a preventative potential for CBD in these arthritides. And it blocks vascular growth factor. For all of these inflammatory situations, an increased growth of vessels and blood vessels leads to greater tissue thickening and more inflammation. And by reducing this sort of pathologic entity, cannabidiol is preserving that joint function and preventing the destructions. So what do you use in the way of cannabidiol for treating arthritis? Now, I think everybody should start with a standard dose, 15 milligrams of the tincture twice a day. Great place to start. I like to move for arthritis, particularly of the autoimmune type, the rheumatoid arthritis or psoriatic, to 30 milligrams twice a day. 60 milligrams seems to be a key point for autoimmune disorders. Now, if you were using liposomes, you might want to use the 10 or even 20 pumps. Key point is to use as much as necessary to get the symptoms under control. At a later time, perhaps a month down the road, you may be able to reduce those dosage so that you can maintain control and also to keep control of costs that would be involved. I want you to adjust early and boldly to the symptom control. And some people may require larger doses of the CBD, and some people may require lesser doses. You have to find out what is important for that individual. And remember that weight has very little to do with the amount of cannabidiol that's needed. Don't forget, you can use the cannabidiol topically. It is superb both for tinctures and liposomes. Rubbed into the area, I typically see a response within 10 minutes with significant pain relief. Do I expect 100% pain relief? No. I would like to think that we'd get 75 or 80% improvement in pain so that that level of analgesics would be reduced. The analgesics like the opioids that are causing so many problems, as well as the non-steroidal anti-inflammatories that are leading to gastric issues, as well as microbiome type of problems. So cannabidiol has a huge potential for dealing with this endocannabinoid deficiency as well as the suffering that's involved with joint disorders. It's got huge potential with regard to preventing the progression of these destructive diseases, the immobility that people have, and the impairment, as well as the huge costs that are involved, perhaps as much as $1 trillion in the near future. Cannabidiol could cut all of that short. And I think the real surprise for you may be that the neuropathic important aspect of this disorder, and that treating neuropathically using the neurotransmitter modulating properties of cannabidiol may be a major portion in the pain control, the immediate pain control that we're seeing with cannabidiol. So this is a great time for me to discuss any other problems and any other issues. I have put some references and my notes into a folder for you. You're welcome to go there, go into that area, pull out whatever files that I have. You're welcome to use those files, and if I can answer questions for you on it, I would be happy to do that.